Hello, everyone. Thank you for joining me today. We're going to have a really special conversation here with Dr. James Muecke. We're just having some technical difficulties with James's connection here. As you can see, James. And okay, so we got some viewers. So it looks like it's working. Okay, so James just needs to turn his camera around. Look, so okay, 1 second. We'll be live in just one moment. We're just going through some technical difficulties. Okay.
Stephen?
Yep, I can hear you there. Have you got me there?
I can't hear you.
You can't? Okay. So we're having some audio difficulties. James can't hear me at the moment. We're just trying to get through this. So James, I haven't got visual there. Okay, so for those joining us today, we've got a very special guest, the 2020 Australian of the Year, Dr. James Muecke. Dr. James is an optometrist and has worked all around the world in helping prevent sugar-related diabetic retinopathy, which is one of the complications of eating sugar that we don't often talk about. And so we're just working through some technical difficulties here. We've got James connected, but we just don't seem to have his audio or camera on. He's just going to reconnect. But so look, I'm really looking forward to this conversation, and because it's not a very common connection that people make from the teeth to the eyes. And recently, within the functional medicine sphere, I've been recommended some optometrists that are doing really good work. And James is obviously one of the best in the world in leading the conversation in how sugar, leads to diabetic complications, into how your vision is affected by your diet. It's, I think there are some very real measurables here that people can take out of, understanding what their diet is really doing to their to their body. Vision loss of vision is something we somewhat accept in our society.
Right.
And James, we're live.
Oh, sorry about that.
No problem.
There's always technical problems, isn't there?
Isn't it? It's always but look, we're very honored to have you today. And it's a huge interest of the functional medicine sphere, and to understand your work, and really how you've dedicated a long time, and some of the title that you received this year of 2020 Australian of the Year. James, I want to just go back a little bit. So the people listening are probably they're quite aware of how nutrition connects to their body, and teeth is one of the first indicators. But I thought this would be a really interesting conversation between us. People don't often talk about the teeth and eyes connection, yet we've been discussing over the last few months how sugar has a commonality in the diseases that people suffer, both in the mouth and the eyes. And I thought that would be a really interesting perspective for people to see. So, I think your expertise is going to be quite eye-opening for people in that sense. But I thought it would be great to go back and, just a little bit into, how you began thinking about, the effects of, long-term chronic disease and diet-driven blindness, and how this, shaped your career.
Sure. Wow, it's a long story. But if I go way back, I wanted to be a doctor for as long as I could remember. And there was nothing specific that drove me down the pathway of medicine that I can remember. I didn't have a parent who was a doctor. There was no inspirational moments in my early life that gave me this spark of interest in medicine. I think I just always had this desire to want to help people, I think. And I also, in my early years, I loved using my hands and loved using my hands to do fine work. I particularly loved, the age of 9, 10, 11, building models and World War II tanks and planes and painting them and things like that. So I always had this idea that I wanted to do medicine and particularly that I wanted to do surgery, and even more particularly that I wanted to do microsurgery. It was something I always had this passion to do. I then had an experience a little later in life. I went to, I'm just going to shut down my inbox so it stops beeping at me. I always had I went for my medical elective at the end of 5th year to Kenya. And that was quite an inspirational time. And during my internship, I was starting to become a little bit disillusioned with medicine for a number of reasons. I'd spent so many years through high school, through medical school, just studying, and just needed a break from that. And so during my internship, the other thing that really started to frustrate me and to disillusion me a bit was the fact that I was mainly seeing patients who had diseases that were chronic, usually self-inflicted, usually related to a poor diet, but particularly smoking back then. This was 30 odd years ago. And so I just needed a change. And so I remembered when I came across this little hospital in the mountains north of Nairobi in Kenya, in a place called Tumu. I fell in love with this place, and I thought one day I wanted to come back and work there. Just had this dream at the time. And so when I had my time during my internship and just needing this change, it just really sparked an interest to go back to Kenya and work for a year as a voluntary doctor. So I wrote to the director of the hospital, and he accepted me, and I headed off to Africa after my time after my internship. So it was a really, really great opportunity to experience something different for me.
Your audio just popped up.
Why that certainly happened. Another technical glitch. Am I back on?
Yep, all good.
Now I've lost you here.
Oh, so we can hear you fine. We can hear you all okay. You can't hear us there. So it looks like your headphones aren't working. So we can hear you okay.
There we go. I'm really sorry about all these technical issues this morning. It's amazing. I've been doing online webinars and podcasts all year, and it's rare to have one that goes smoothly. Interesting. So where was I? Sorry. So in my internship, I was becoming disillusioned. Then wanted to have a break from what I saw as a sort of chronic disease driven medicine here, where you're really just prolonging life, alleviating symptoms. And so the idea of going back to Africa was one that was very appealing. And it really did reinvigorate a love of medicine for me, because I was now for the first time dealing with patients that had mainly diseases that were not self-inflicted, that were related to predominantly infectious diseases such as malaria, TB. So it also instilled in me a desire to pursue a career in public health. So at that point in time, the idea of working in public health in poorer communities, in poorer countries, but also combining that with an idea that I wanted to use my hands to do surgery, and particularly microsurgery, really fueled this desire to do ophthalmology, to become an eye surgeon. So I headed back to Australia after that year in 1990 to start my training in ophthalmology in Adelaide. So that's a bit of a long story, but that's where it all began, really, yeah. And so I did my 3 years of training here in Adelaide, and then as soon as that had finished, I wanted to go back and immerse myself in a poorer part of the world, and I headed with my wife to Jerusalem to work at St. John's Eye Hospital for a year, and that was another brilliant year, which then fueled that passion for fighting blindness in poor communities.
it's a fascinating journey, isn't it? You know, when you kind of look back as to how a career manifests like that. So it's fascinating to hear, you know, how your passions kind of drove you in certain ways. I'd love to hear, you know, what you've experienced on the ground, because I think this is something that people don't appreciate so much, how chronic eye diseases manifest in people, and how you saw this in, you know, say, you know, poorer communities. And, you know, what are some of the you know, I mean, people are aware of diabetic complications of, I thought we'd cover that more so later. But what were the things that kind of really opened up your eyes as to how people can become really sick with their vision?
Sure. And actually, another interesting little sliding door moment, I missed out on. I actually went to high school in Canberra, missed out on Sydney University of Medicine by 1 mark. Amazing. And so I came to Adelaide to do medicine. That's how I ended up in Adelaide. But yeah, so you know, there are a number of very powerful experiences that I've had, which really, for me, drove this desire to continue working and really build a passion to want to help people in poorer communities. Initially, the interest was the fact that I could cure blindness using my hands. And my personality is one, I like to have a result. I like to have a project and to be able to complete the project. I was always fascinated by psychiatry, for example, but you know, I just didn't feel that I was able to satisfy my personality in that sort of specialty. I needed to have results where I was able to cure patients. And so curing blindness, you know, using my hands was just something which was fascinating and appealing to my personality. And cataract is the leading cause of blindness in the world. Well, about 50% of the world's blindness is due to cataract blindness, but in poorer parts of the world, it's probably closer to 90% of the blindness. So, you know, you had a real opportunity to be able to give people back their sight and really make a difference, because we know that when money is invested to fighting blindness, it also helps fight poverty. It's quite a powerful thing. So what's interesting is that although cataract is the leading cause of blindness in the world, there are quite literally hundreds of eye diseases. Many are blinding and some are deadly and disfiguring. And so many of these diseases had been neglected in poor communities and had been neglected by some of the large organizations working in this field. And so during my early years, when I came back to Australia after my time in Jerusalem, after Jerusalem, I went on to London to study eye cancer and then came back to Australia and settled here in 1998 with my family. But to keep this love of being involved in fighting blindness in poorer countries alive, I started getting involved in a number of research and teaching projects in Asia, and that continued to fuel this desire. And what I saw as part of those experiences was really, really powerful. And I think the first one that was really powerful for me was in 2005. So I was involved in an adult blindness study in Myanmar in Southeast Asia. And we were trying to determine the prevalence and causes of blindness in a rural part of the country. And the results of the study, in fact, every day, you know, I would be assessing about 100 subjects in different villages in this regional area of central Myanmar. And I was just staggered at the amount of blindness that I was seeing. And the prevalence of blindness that we discovered over the months of that study was about close to 8%, what they call presenting blindness. 8% of people were blind, you know, which is quite staggering, nearly 1 in 10. And a much higher proportion of subjects were actually visually impaired. So I was in my early 40s at the time, and I was seeing people who were younger than me, who were, you know, in their early 40s, who were blind from cataract. This is something, we see a lot of cataract here in Australia, rarely people who are severely blind, and certainly not at that age. So this was something that was such a unique thing for me to experience. And then it really did drive a desire to want to help in that respect. And so when we came back to Australia, and what was also interesting, even the patients who'd had cataract removed were still blind, because quite often they either didn't have the glasses to be able to correct their vision after the surgery, or the surgeon in that location had put in the wrong power lens, and so more often than not, they were still visually impaired or even blind. And so one thing that I was trying to think about at the time was, well, why are people becoming blind at such an early age from cataract? Why are they developing cataract so aggressively at such an early age? And it was a rural and very hot part of the country and a dry part of the country. And before the study began, I would go out and roam the village and take some photographs. And I was noticing people working in the fields, and the farmers were very much a subsistence population, and exceedingly hot, even sort of early in the morning. And so my theory was that perhaps there was a dehydrational component to this, that this was perhaps somehow driving the development of cataract at an early age. I mean, in Australia, everyone will develop cataract because they live long enough. So it's what we call senile cataract. And so I think we were just simply the same cataract, but just developing at an earlier age. So when I got home, once we published the study, I then felt that I really wanted to do something here, and ended up with my colleagues coming up with a significant proposal to AusAid. Now AusAid has been pulled in under the Department of Foreign Affairs and Trade, but back then it was AusAid, and we were successful to receive a grant from AusAid, which allowed us to go back to over 30 regional eye centres through Myanmar and make sure that they had the appropriate equipment to be able to not only treat cataract blindness surgically, but also to be able to diagnose it. Quite often in the regional centres, they didn't even have the basic tools to diagnose patients with cataract or anything beyond cataract. The basic tool that we use is what's called a slit lamp microscope, and so they didn't have these in a number of eye centres. So quite disheartening for a doctor to train as a doctor and then train as an eye surgeon and then be posted out to a regional centre and not be able to do anything. So we made sure that they had the slit lamp microscope so they could make the diagnosis. We made sure they had what we call the operating microscope so that they could actually operate on cataracts, and made sure they had the appropriate equipment, but also the appropriate equipment to then be able to determine, to calculate the power of the lens that needed to be put inside the eye. And so once we did that, then this has a huge impact. The work that I'm passionate about is not going to a country and doing surgery, and unfortunately that still happens across the board in many specialties, many medical specialties, I suspect in dental areas as well. But to me, the most powerful way is the teach a man to fish strategy, to make sure they have the equipment and the skills to be able to continue to do the work. And so this is the model that Sight for All has developed. And so, we've seen a huge growth in cataract surgery in those regional centres that we've supported over many years now, actually, since that study back in 2005. And, the cataract surgery that's being performed is high quality for that setting. They're getting great results. And what happens is that filters back to the village level. And people see that the local eye surgeon is now doing good quality surgery, and it inspires them to then have their cataracts removed. And so that not only improves the quality, but also improves the quantity of their work that they're doing. So that was one thing. And I think the other really, just in adults, cataract blindness is the leading cause of blindness. As I mentioned, there are hundreds of other eye diseases. And so we saw that there was a huge need. Our colleagues in Myanmar really needed training in all of the subspecialty areas of the profession. At that time, so back in the 15, 20 years ago, the internet was illegal. The textbooks that they had were old and out of date. And so they were absolutely desperate for any education we could provide. So I set up a subspecialty training program, and then that ultimately evolved in 2008 into Sight for All. But that was also driven by another really powerful experience in Myanmar in 2007. I was involved in the childhood blindness study. So pediatric ophthalmology is quite a different entity to adult ophthalmology. It's its own subspecialty. But what we found in that study, which was a national study looking at the causes of blindness amongst children, and so we went to 7 schools for the blind across the country to assess the kids, and what we found was really staggering. We found that nearly half of the kids had blindness that could have been prevented or treated. So half were needlessly blind and shouldn't have even been at those schools. But the thing which was really powerfully impacting on me and actually the entire team was the leading cause of blindness that we found, which was which was measles. So measles blindness, absolutely staggering. Measles blinds in a painful way, but it also blinds in a terribly disfiguring way. And then to be surrounded by kids in 7 schools for the blind who are disfigured and irreversibly blind was one of the most powerful experiences of my medical life. And that really did drive a huge passion to do something about it. And it was one of the instrumental moments for me in setting up Sight for All, so we could deal with this. At the time, 2007, when we undertook that study, there was no children's eye specialists in the country. So I went back to Myanmar after we published the results. I met with the health minister and persuaded him that we needed to train a pediatric ophthalmologist. So we brought a young eye specialist out to Australia, trained here at the Women's and Children's Hospital in Adelaide, and he went back in 2010 as the very first in his country. We set him up in the country's first children's eye unit, where he works to this day and is now providing close to 30,000 treatments for kids every year just by himself. But what's even more impressive is that as his competence and confidence grew, he started training his own colleagues in 2015, finished training the second pediatric ophthalmologist, and he now trains at least two every year. So it just shows you the scalability, the sustainability of the work that we do. So that's just a couple of examples that has really driven the passion and the work that we do with Sight for All.
It's amazing to hear, how impactful and how important, I think people really take for granted, how fundamental sight is to health. And, just hearing your stories, it's really kind of striking me, how that we, even in, say Western society, we probably don't, we don't think of our eye health in this, in a way that, that we can intervene. I'd love to dive into a little bit into some of the nitty gritties of cataracts so people can understand that, with your speciality, can you describe the pathology of cataracts, what they do to the eye and how you treat them?
Sure. No, I'm very, very happy to do it. And just on another note related to the previous discussion, we actually found that measles was a leading cause of blindness in 2 other countries where we did studies in Cambodia in 2008 and in Laos in 2013. But amongst the sea of children who are blind from measles in each of these 3 countries, we actually occasionally found children who are visually impaired, even blind, because they've never been tested for spectacles. Quite simply because there often was no one in that country, in that area, to be able to provide spectacles for them. So again, another highly preventable cause of blindness. Measles is a very preventable cause of blindness, and a lack of spectacles is clearly a preventable cause of vision loss and blindness. So coming back to the cataract story. So the lens of the eye, which sits just behind the pupil, which is the dark hole in the iris, which is the colored part of the eye. And for the listeners that don't know the anatomy of the eye, the lens is what's involved in focusing. If we didn't have a lens, and you may have seen images of people who've had cataracts removed, but no lens replaced. Before we had the technology to put a plastic lens inside the eye to replace a lens that's been removed, they needed very thick lenses to be able to focus the light rays back onto the retina. So the lens is very important in focusing the light rays onto the retina so that we can see, and particularly focusing the light rays into the central vision area, what we call the macula. And so the lens of the eye is actually, sits, as I say, just behind the iris, behind the pupil, and is suspended to the inner wall of the eye by a series of very fine, what we call fibrils. And each of those fibrils is about 1% of the diameter of human hair. And the lens itself is surrounded by a capsule, which is about 10% of the thickness of the finer cellophane. So the lens matter with age becomes denser, and that's what a cataract is. Essentially, there's a thickening of the lens matter, a yellowing of the lens matter, and that in turn causes blurring of vision, a gradual blurring of vision. Interestingly, the most common type of cataract is what we call nuclear sclerosis. So it's a hardening of the lens matter. And what happens there is that as well as reducing the ability for the light rays to pass through the lens, it also hardens the lens, so we aren't able to focus as well as we do in our younger years. So, and there are actually a number of different types of cataract, but the commonest type is this hardening of the lens, yellowing of the lens, and that in turn results in blurring of vision, which ultimately, and it takes some years, many years often, for it to really impact on people's vision, so that, for example, they can't drive, or worse, they ultimately can become blind, like they were doing in Myanmar, because they didn't have access to good quality eye care. So to remove a cataract, so these days in Australia, we use a technique called phacoemulsification. We make a small cut in the cornea, we pass a probe into the eye. We actually have to make we have to dilate the pupil, and then we have to make an opening in the capsule that surrounds the lens in order to access the clouded lens matter that constitutes the cataract. And that probe, we then pass it into the lens matter, and it emits high frequency ultrasound, and that breaks up the clouded lens matter, and then you're able to suck it out of the eye. So the surgeon has to remove the entire contents of that capsule. It's about 1/4 milliliter, without rupturing that very fine capsule or without displacing the lens from its location at the front part of the eye. So surgery doesn't get much more precise than that, or thrilling. And that was one of the other things that was really appealing for me as a surgeon, to be able to do this fine work and to be able to restore sight. So yeah, in a nutshell, that's how cataract surgery works. Once the cataract or the clouded lens matter has been sucked out of the eye, we then put a plastic lens back into the capsule. And that in itself is a very elegant procedure. It's a tiny little fine plastic lens which is folded up, inserted into the capsule with a special device, and then it unfolds into the capsule and sits there for the rest of the patient's life, focusing those light rays back onto the retina. And there's a way of determining the power of the lens so that the light rays are focused and the patient isn't left, let's say, long or short-sighted, as many of those patients were that I mentioned from Myanmar during that study in 2005.
It sends chills down my spine as to how accurate and how detailed that surgery is. It's amazing. James, in terms of risk factors for cataracts, what are some of the lifestyle factors that are popping up is in the literature now in terms of people that are higher risk in the Western world? Is that discussed in the ophthalmology world?
Oh yes. So I mentioned before that the leading cause of cataract is senile cataract, and just simply the hardening of the lens and the discoloration of the lens as we age. That's just life. And there's cataract in itself. That type of cataract is not preventable. It's highly treatable, of course, but it's not preventable. But there are many other causes of cataract. I could name a few. For example, trauma. If someone has a knock to the eye, that can cause cataract. If someone's on steroid treatment, prednisolone, for, let's say, autoimmune diseases or other conditions, steroid use will ultimately cause cataract, and if not dealt with, can actually lead a patient to become blind. Chronic inflammation in the eye can cause cataract. The list goes on. There are genetic causes, inherited causes. So childhood or congenital cataract can be often inherited from parents, or to be a new mutation in the child. So there's a whole spectrum of reasons why someone can develop a cataract. And as I mentioned, in poorer parts of the world, I wonder whether there's a dehydrational component that may be at play, particularly in very hot parts of the world. Perhaps also nutritional elements as well. And in fact, I mentioned before about measles, blindness in kids. That was probably driven in part by a poor nutrition. So when someone contracts measles, when they're healthy, it's not a nice disease, and actually can be quite a devastating disease. But we rarely see the serious complications of it, or for one, because most of us are vaccinated, but two, if you're otherwise healthy, it's not such a desperate disease, as it would be in a poorer part of the world when you have poor nutrition. It can actually turn measles into a deadly disease and also a potentially blinding disease, and have a whole range of other very serious complications.
One of the the complications of of type 2 diabetes is blindness, and I thought the connection between sugar, and because that's something that obviously your work has been focused on, here in Australia in the last year, and as Australian of the Year, I thought it'd be interesting for people to start to learn, what is the connection and what is the mechanism of diabetic retinopathy, and how sugar does affect their eyesight over the years, and this connection between what we eat and the eyes is fascinating, and your experience through through third world countries and very poor people that don't have access to good quality nutrition. It's an amazing interface as to how we can think about to get better quality eyesight right throughout the world. How would you describe how sugar affects the eye?
Sure, and it's an interesting journey for me as well, Stephen. When I mentioned before, when I was in my internship, being frustrated, disillusioned by just dealing with patients who had chronic self-inflicted diseases, and virtually all of those were avoidable, preventable, and so I just wanted to be able to cure patients, and that's why cataract surgery was so appealing to me. And then to come back full circle to experience blindness amongst kids, which was highly preventable due to things like a lack of measles vaccination or a lack of spectacles, I really did come full circle. And for the first time, it drove home how critical prevention is in modern healthcare, not just in medicine, but of course in dentistry as well. And really, I've been an eye surgeon now for 30 years, and for 30 years I've been dealing with the consequences that diabetes inflicts on the eyes. And every year I'm seeing more and more patients who are losing vision, even going blind due to this disease, but particularly type 2 diabetes, which makes up about 90% of cases, and is a largely preventable dietary disease related to the consumption of too much sugar in our diet. And I was seeing the end stage complications of something which was entirely avoidable, a disease which was entirely avoidable. And to be honest, I hadn't really thought about the underlying cause, what the root cause of type 2 diabetes was. I felt that was the domain of the general practitioner and the dietitian, and really didn't even give it too much thought. And then in 2018, I met a man whose story was incredibly powerful. He went to bed one evening at the age of 50 and woke up the next morning quite literally blind in both eyes. And this was a few years ago, 6 years ago, in fact, and sadly, to this day, still remains blind. One of my colleagues, a retinal surgeon, worked really hard to try and restore his sight. Unfortunately, though, it was too late, and so he's now living the rest of his life in darkness, and has become an incredibly powerful advocate for it. So how did he go blind? Well, let's wind back a little bit. So with diabetes, and both type 1 and type 2 diabetes, which are the major diabetes subtypes, cataract can actually develop at an earlier stage, does develop at an earlier stage due to sugar imbalance within the fluids inside the eye. So cataract is one of those things that can develop earlier. But the really vision-threatening complications of diabetes are really twofold. The first is that blockage of blood vessels in the retina leads to a lack of oxygen flow in the tissue of the retina, so what we call ischemia, so retinal ischemia. And when we have large areas where there's retinal ischemia, the injured retina actually releases factors into the chemical factors into the jelly of the eye, and that actually can trigger the growth of new blood vessels, what we call neovascularization. And those new blood vessels are actually trying to heal the damaged or ischemic retina. but they're abnormal and they're fragile, and they can actually bleed into the jelly, which fills the inside of the back of the eye. So one of the most sudden and devastating causes of loss of vision and blindness is what we call vitreous hemorrhage. So the vitreous is the jelly, so hemorrhage or bleeding into the vitreous of the eye in one and rarely in both eyes at the same time. That's quite an unusual story, fortunately, but certainly it usually presents as a sudden loss of vision in one eye with floaters due to the blood drifting around in the jelly at the back of the eye. So the other major complication, the ophthalmic complication, is damage to the fine blood vessels, which then causes leakiness of those blood vessels. And when the leakiness happens at the macula or the central vision area, you get fluid or fluid seeping out of the blood vessels into the tissue of the retina at the macula, and that causes blurring of vision, sometimes distortion of vision. So on one hand, you have bleeding causing floaters and a sudden loss of vision. On the other hand, you have leakage of fluid at the macula causing what we call macular edema, diabetic macular edema, and that manifests as blurring or distortion of vision. So they're the two major complications. If the bleeding is left unchecked and the ischemia is left unchecked, we get growth of abnormal blood vessels into the front part of the eye, and that in turn can cause pressure rise in the eye, what's called glaucoma, and that can actually destroy the eye. And myself, as an eye cancer specialist, I have the sad task of occasionally having to remove eyes of adults and of kids with cancerous tumours. So I'm the guy in Adelaide that tends to remove most people's eyes, and so occasionally I have to remove eyes of patients whose eyes have been destroyed by their diabetes. So that's pretty devastating. And that's the worst case scenario, of course. So when we have bleeding into the eye, there are a number of treatments that we can engage. Sometimes the bleeding clears by itself. Occasionally we need to do what's called a vitrectomy to suck the blood out of the eye. And once we have a clear view of the retina, we then do laser treatment, and we do 3,000 to 4,000 spots of laser throughout the retina, except for the central vision area, over 4 or 5 sessions. And what that does, it actually destroys the retina in the area where you've lasered, and that in turn is said to reduce the release of those chemicals which are triggering the new blood vessel formation. And then hopefully that allows the new blood vessels to regress, and then for that risk of further bleeding to no longer be there. So that's a vitreous hemorrhage with the macular edema. What we used to do until perhaps a decade ago was do very fine laser burns to the tissue of the macula, but not right at the very center of the macula, which is called the fovea. And that in turn, that gentle laser, rather than the destructive effect that it has with the peripheral laser I talked about before, actually triggers the reabsorption of the swelling that's occurring there. So it's not actually healing the leak, it's just triggering a heightened reabsorption of that fluid. But the problem is when the damage is quite severe, then that laser doesn't actually work. But these days we have a more effective treatment which involves injection of an antibody into the eye. So the substance which causes the leakage of fluid and also causes the growth of new blood vessels is what we call vascular endothelial growth factor. So the antibody that we inject into the eye is an anti-vascular endothelial growth factor, anti-VEGF. And there are a number of anti-VEGFs that we have these days. And when we inject that into the eye, it actually regresses new blood vessels, only temporarily, and that's why we need to supplement it with a peripheral laser. But an interesting effect is that it also seals up the leaky blood vessels at the macula, at the central vision area. And so that then allows the swelling or the edema to reabsorb, but unfortunately it's only a temporary thing. So patients who go on to this pathway of needing injections into their eye, when they have diabetes, most of them will need to have this on an ongoing basis initially we start off giving an injection into the eye on a monthly basis. And if we're getting a good response, we might then be able to increase that to 2 monthly, even 3 monthly or beyond. And sometimes we can actually stop it, albeit temporarily. So once they start on this pathway, often patients are having these injections really for the rest of their life. And in Australia, these days, there are, well, last year, 2019, there were over 93,000 injections given for patients with type 2 diabetes every year. I suspect we're now up to the 100,000 mark. So this is 100,000 injections given every year, when really this should not be happening at all. And so this is something that really does trouble me greatly.
It's a very stark description as to, you know, what you're describing, such delicate structures in the eye that are so affected via the you know, the long-term consumption of sugar. And so, you know, in type 2 diabetes, you know, we see increased blood sugar, increased inflammation, which you've described as, you know, primary risk factors for disease in the eye. It's fascinating, isn't it, that, you know, these kind of conversations between, you know, what I see in the dental chair, you know, tooth decay, and, you know, the effects of sugar in the mouth, it really is describing a very similar disease mechanism, which is the long-term dietary intake of these of sugar that really does drive this disease process. In terms of, you know, managing, I mean, I'm not sure how detailed you go into this with your patients, but how would you describe risk for, you know, for people thinking about or maybe experiencing some of the earlier signs of vision loss, you know, in terms of the connection to pre-diabetes, blood sugar levels, you know, what are you seeing in terms of where we can start to interface a preventative model here to stop the, you know, the end stage treatments that you're describing?
Absolutely. Well, as you mentioned, yourself as a dentist and myself as an eye specialist, we're just seeing two of many, many devastating complications of this disease, life-changing complications, life-threatening complications. And just briefly, just to the listeners, there are quite a number. In fact, this disease ravages the entire body. So we have blockage of fine blood vessels throughout the body and blockage of major blood vessels throughout the body. And the big driver here is the high blood insulin level. Often what's treated, what's dealt with is the high blood sugar level, but what's really the big driver of this disease is the high insulin level, and none of the medications that I'm aware of, certainly the ones that we've had in place for many, many years, actually deals with a high insulin level. So the high insulin level combined with the high triglyceride level in the blood promotes the formation of fatty plaques, which then block the blood vessels throughout the body. So this is, as I say, devastates the entire body. So blockage of the fine blood vessels can give rise to the ophthalmic complications. And I suspect also we have a contribution here to damage to the tissue of the gum. I suspect there is an element of ischemia that happens in the gum tissue, which promotes some of the oral complications of this disease. But it also causes impotence. It causes numbness, pain, tingling in the hands and feet due to damage to the peripheral nerves. It causes dementia. Something like 70% of patients with type 2 diabetes will develop dementia. And having lost a father to dementia, you can see how it impacts on the entire family, not just the individual. It causes kidney failure, and when the kidneys fail, the blood needs to be filtered. And something like 4.5 million hours are spent hooked up to a dialysis machine by patients across Australia with type 2 diabetes. So this is time lost to friends and family, time lost to things that they love to do, and to their workplace, of course. Now, damage to the major blood vessels can result in gangrene, and gangrenous feet and legs often need to be amputated. There's over 4,000 amputations performed every year in Australia for patients with type 2. Then we can also see the major life-threatening complications, which are stroke and heart attack, which develop in about 80% of patients. So that's just really setting the scene for this very, very severe impact that diabetes, and in particular type 2 diabetes, has on the body. And sorry, Stephen, I lost your original question. I was really trying to set the scene. Just remind me what.
Well, no, you described it very well. So I mean, what I'm trying to get across is that, you know, for people to kind of understand, you know, how this, you know, and how sugar intake, on a daily basis will, sets up their body for long-term sickness. So you've really established that. And the, increased insulin, triglycerides in the blood, these are the factors that, and these are, somewhat people can measure this and understand this. So the understanding here of what's happening, as you say, in the gums, in the teeth, this is what people know and have known this for a very long time now. But then how you describe very well this pathology in the eye, it becomes very clear these very fine blood vessels are being affected by this systemic inflammation, increased insulin resistance, and the lack of healing ability in the body. James, there's just a question here on that I thought we'd take, just because we've got your speciality here. But can you elaborate a little bit further on glaucoma?
Sure. So glaucoma, there are, a bit like cataract, there are a number of types of glaucoma. There's a congenital glaucoma. So glaucoma can appear in childhood, and that's often related to genetics. But the commonest type of glaucoma is what we call primary open angle glaucoma. So chronic open angle glaucoma, primary because we don't know what causes it, but there's a genetic element here. So at the front, I mentioned before that the back of the eye is filled with jelly. The front part of the eye is filled with a fluid we call aqueous humor, and that's produced just behind the iris, something in a structure called the ciliary body, and then the fluid percolates through the pupil and then it's absorbed in what we call the angle of the anterior chamber, which is the front chamber of the eye between the cornea and the peripheral iris. So it gets absorbed through something called the trabecular meshwork. So with primary open angle glaucoma, that trabecular meshwork through genetic means becomes blocked. And so you get a buildup of fluid, a reduced drainage of fluid, and that causes a rise in pressure in the eyes. And that rise in pressure in turn can cause damage to the main nerve, what we call the optic nerve at the back of the eye. And that in turn results in damage to the vision. It often starts out in the periphery where we don't know and don't realize it's happening. It's doing damage. It's a bit like high blood pressure. It's doing damage, but you're not aware of it. It's often called the silent assassin of the eye. So glaucoma, it's the commonest type of glaucoma. But then we also have a secondary open angle glaucoma. Interestingly, I mentioned before prednisolone or steroids causing cataract. They can also cause a secondary type of glaucoma as well. Trauma can also cause glaucoma, and there are a number of other reasons, inflammation in the eye. So quite often, many of the causes of cataract or secondary cataract also cause a secondary type of glaucoma. And yet there is another type of glaucoma that we call angle closure glaucoma, where the angle, the drainage angle that I mentioned before, becomes blocked. And that can present acutely with a painful eye with exceedingly high pressure. And it's often related to the anatomical structure of the eye. And interestingly, in Myanmar that I mentioned before, the commonest type of glaucoma is an angle closure type of glaucoma in those people. And interestingly, in the Aboriginal population of Australia, we actually don't see glaucoma happening at all. So there's significant genetic elements to this. So hopefully that's answered the question. There is a whole range of glaucomas, but the most common is the chronic primary open angle glaucoma, which is generally treated with drops to reduce the pressure. But when those drops don't work, we have laser as an option, and then ultimately surgery as an option as well.
How would you recommend that that people begin to think about their eye health in terms of, we'll definitely end on our recommendation on sugar, but general care for their eye, and when should people be starting thinking about getting their eyes checked, and what should they be looking out for?
Sure. I mentioned before that I'm an eye cancer specialist, so I quite often see patients with sun damage on the surface of their eye, and that in turn can lead to a cancer developing on the surface of the eye. And I have one of the largest series in the world of eye cancers on the surface of the eye, and quite often patients in rural communities and quite often farmers. And I know as a child myself, I often didn't or I don't think I ever wore a hat as a child, and certainly didn't start wearing sunglasses until I was quite a bit older. And I suspect out in many rural areas of our country, people are not wearing hats and sunglasses, and certainly at school. And I remember when my kids were at primary school, they all had to wear hats when they were out on the playground, which was great to see. So certainly I think from an early age, encouraging your kids to wear hats and sunglasses is a really good idea. Generally, I would say most people, though, won't have their eyes assessed unless they're having problems, unless they're having blurred vision or other symptoms which are alerting them to a problem that's existing. I would say probably into the 40s, once people reach their early 40s, they start to have difficulty reading because, as I mentioned before, the lens hardens, and so you're not able to focus up close so well. So you start to have difficulty reading fine print, and then you have to hold it further away, and to such an extent that you can now no longer see the print. So you actually need magnifying glasses to bring the print closer towards you. So reading glasses, once you start using or needing reading glasses in your early 40s, are simply magnifying glasses to bring the print closer to you. And that goes through to about the age of 65 when you no longer have any focusing power at all. So from the early 40s through to mid 60s, you need stronger and stronger reading glasses. And then ultimately, people often then start to get blurring and need cataracts removed. So I would say generally in the early 40s, when you're starting to have those early symptoms of blurred vision up close and near, go and have a check with your local optometrist. And we're fortunate to have thousands of optometrists across the country who are excellent at prescribing glasses, but also excellent at screening the eyes for diseases, picking up diseases at an early stage, and then referring them on to the ophthalmologist if there's something of concern there. So that's a really good mechanism that we have in Australia, and we were talking before. In fact, that was what I wanted to get onto was the situation in patients with diabetes. Patients with type 1 diabetes, which they tend to be younger patients, although we're seeing type 1 diabetes happening in later and later in life. It's an autoimmune disease. Because it's such an acute and it's a very life-threatening disease, the damage to the eyes won't be present at diagnosis. So generally, patients with type 1 diabetes, we don't recommend they have their eyes screened probably until about 5 years after the diagnosis. And then we'll see, probably they would normally see the optometrist, occasionally might see the ophthalmologist if the GP refers them to us. And if there's no sign of any diabetic damage, what we call diabetic retinopathy, then I would normally see the patient every couple of years. Generally, the optometrist would see patients every year. With type 2, problem with type 2 is that we don't know how long the patient has had that type 2 diabetes for. Generally, we don't see damage in patients with prediabetes. I'm not aware of that. But with type 2, how long have they had the disease? We don't know. So as soon as the disease is diagnosed, then they need to have their eyes checked. And a significant proportion of those patients will have diabetic retinopathy at diagnosis. And many may also require immediate treatment. There are about 100,000 or more Australians with what we call vision-threatening diabetic retinopathy. They may have new blood vessels growing, or they may have edema, either threatening or involving the macula. So those patients will need to have immediate treatment or very close observation at least. So if a patient has early retinopathy but not vision threatening, I would see them myself on a yearly basis. And if they have vision threatening disease, if it doesn't require treatment, if I'm watching them, it might be every 3, 4, even 6 monthly. So that's kind of spectrum. And the patients who have diabetes, they will notice as well with fluctuations in their blood sugar that will cause temporary blurring of vision. But when the blurring of vision is more permanent or starting to deteriorate, then they absolutely should come and have their eyes checked. Now, the sad thing in Australia is that more than half of the 1.7 million Aussies with diabetes are not having their regular eye checks. So more than half are putting their sight at risk. Their risk going blind, like the gentleman I mentioned to you before. So absolutely critical for people with diabetes to have their regular eye checks to prevent this really devastating outcome. It's not something that people want to experience in their life, potentially irreversible blindness. So definitely one message I like to encourage, one message I've been talking about this year is ensure if you have diabetes, have your regular eye checks.
You're speaking of a very preventable model of closer understanding and a critical arm of people's long-term health and longevity. So it's fascinating work, and something that I think that it's so admirable that you've been able to get this message out to the broader community, because it's very simple to understand once we see how important it is. James, how did you've been campaigning for a broader understanding and reduction in the consumption of sugar to help build this interface of preventable understanding between the connection of blindness and diabetic complications. How would you describe what people can consider, and what you would hope to be some of the future steps we can take to reduce the consumption of sugar?
So just on the loss of vision and blindness, something like 98% is preventable or treatable. So we just should not be seeing loss of vision and blindness at all. But what really actually makes me angry is that we shouldn't be seeing type 2 diabetes at all. As I mentioned, it's a largely preventable dietary disease related to excessive sugar consumption in our diet. And so if we're calling this a preventable dietary disease, then surely there's a dietary cure, and it should be as simple as reducing the amount of sugar and refined carbohydrates, which to me, I call them sugar in disguise. But there are a number of factors that make this much more difficult to achieve. And I came up with this concept earlier in the year when I was, Australia Day weekend was approaching. I wasn't expecting to win the award actually, but I thought I better be prepared. And I felt that I had a deeper responsibility if I did win the award to really highlight this devastating disease to the people of Australia and the toxic impact of sugar in our society. So this responsibility is what I've carried forward this year, and the messaging has really been about trying to reduce our consumption of sugar and refined carbohydrates in our diet. But there are a number of factors that make this a really difficult thing to achieve. So I came up with this concept called the 5 A's of sugar toxicity. Firstly, sugar is highly addictive. It's been shown to be as addictive as nicotine. So its consumption activates the reward center in our brain, leading to the release of the neurotransmitter dopamine. And so that's what makes us feel good, and it makes us what makes it a really difficult habit to kick. Second A is alleviation. We often use sugar to alleviate stress or to make us feel better when we're down. When we're stressed, the body is flooded with cortisol, the stress hormone. So the brain needs to balance that up by releasing feel-good chemicals such as dopamine, and sugar does a really good job of that. Also makes it a very difficult cycle to break. Third A is accessibility. Our world is flooded with cheap and highly available sugar. You can't walk into most service stations these days without being confronted by a wall of confectionery. You can't check out from most supermarkets and stores without being enticed by half-price chocolates and soft drinks. And fourth A is addition. Something like 75% of our food and drinks have added sugar, and yet there's no clear labeling system to tell us the amount of added sugar contained within. We have a health star rating system, which is flawed. It's flawed on a number of levels, but it's flawed particularly because only 30% of manufacturers are actually using the label. And the fifth A is advertising. Our world is flooded with ads and TV commercials for sugary products, often in insidious and predatory ways. And so it's these 5 A's of sugar toxicity that really make it very, very difficult. We also have, in addition to that, we have a dietary guideline, which is flawed, and it's heavily biased and conflicted by industry influence. So all of these things are making it very, very difficult. So in terms of how do we deal with this, I like to think of it in that structure of the 5 A's of sugar toxicity. So for addiction and alleviation, it's about awareness. For me as a doctor, until about a year ago, I had no idea that sugar was addictive and that we were using it to alleviate stress. So how does the common person in the community have any idea of the addictive power of sugar? So that's one thing. And then if you're aware of how addictive it is, you can then put in place a strategy to try and detox from sugar and get through that process. And the other 3 A's accessibility, addition, and advertising, really about accountability. So these two overarching A's of awareness and accountability makes it 7 A's really. The accountability of businesses, industry and government to do the right thing by the people of Australia. So in terms of accessibility, a number of strategies. One would be to remove sugary products from vending machines. I was in the Adelaide Medical and Dental School, and there were 2 vending machines in the study area packed to the brim with sugary products. This is our bastion of health, dental and medical health, promoting sugary products. Also removing sugary products from checkout counters where they're preying on the vulnerable and they're preying on our kids. As you're aware, those sugary products are often set at the eye line of children. In terms of addition, we need a clear labelling system to show people how much sugar is contained within. That is really critical. If they're going to use the Health Star rating system, it really needs to be mandated so that everyone is using it, because things like orange juice with the current system gets 5 stars, and yet a glass of orange juice has almost as much sugar as a glass of cola. Go figure. And there are a number of other unhealthy products that have been, the algorithm has been designed by industry to give those unhealthy products a healthy rating. And, this is where that contentious issue of taxing sugary products comes in. And we can come back to that in a moment. When I won my award and I was in Canberra, and the political journalists were really interested, of course, on my comments about a tax. So it was all about Dr. Muecke calling for a sugar tax. But as you can see, this is a systemic problem, and we need a broad strategy. It's not just about a sugar tax. The 5th A is advertising. Again, an obvious thing would be to remove ads for sugary products, which are aimed at kids during those hours when our kids are watching TV. Also, to deal with the predatory marketing for sugary products on social media. We need an awareness campaign to make Australians aware of the toxic impact of sugar and what excessive consumption of sugar does, but also for patients with type 2 diabetes, the devastating life-changing and life-threatening complications which impact on them and their families. People need to be aware of this. But there's also some really important messages here that, 1, type 2 diabetes is preventable, largely. 2, that it's also reversible. We now have 3 strategies that we have that can reverse type 2 diabetes, even quite late diabetes. Sadly, unfortunately, we can't always reverse some of the complications that have happened, but there is an opportunity here to reverse type 2 diabetes and potentially limit further damage down the track. And so this is really critical information. And another critical piece of information is the natural saturated fats in our diets have never been shown to cause cardiovascular disease. These fats, particularly full fat dairy, eggs, unprocessed meat, even dark chocolate, these have been demonized for the last 40, 50 years, and yet there's no evidence that they cause heart disease or stroke. Really important information, and yet our dietary guidelines continue to demonize fats and continue to celebrate carbohydrates, which for the most part are non-essential. There's not a single biochemical process in our body that demands that we have ingested carbohydrates, so they're non-essential and potentially doing damage if we're eating them to excess. And something like 2/3 of our intake is carbohydrates these days. So, some really important messages that need to be communicated to people. And the dietary guidelines that we have are, someone said to me the other day, well, I didn't even know we had dietary guidelines. Well, they're actually really powerful. They inform what's eaten in schools, childcare, aged care, prisons, the defence forces, and in hospitals. But they also inform health providers, health educators, government policy makers, and also the food industry. There's been quite literally thousands of low-fat products built on the back of these guidelines, yet with no evidence that has to be the case. So there's a broad systemic strategy that just needs to be reversed. We actually need a paradigm shift here, Stephen. And I know that it's not just sugar that causes the dental decay, the dental caries, but it's also the refined carbohydrates. There's now a link between things like white flour, products made from white flour such as pasta and bread, white potatoes and white rice. These are also a big driver of type 2 diabetes, obesity, and dental caries epidemics that we have in our community in Australia.
James, you describe the broader societal picture so well, and it's interesting to sit with you to hear about how you came to this point, to have such an advocate for broader societal understanding of these factors that are so important for many people's lives. For someone that's worked so closely on on helping people see again, and overcoming the complications of one of the most delicate parts of the human body. It's really fascinating, and I thank you very much for your work, for connecting people to light, to helping them see. And the way you describe this dietary problem, it's one of the better descriptions I've heard. So I applaud you so much for your work, and thank you for all the dedication you've had to spreading this message. And I can only hope that there are more conversations like this, and that we'll be talking about this more and more into the future. So thank you so much for spending the time with us today. And we really support your work, and hope to be hearing more about it soon.
Thank you so much, Stephen, and thank you for having me on the show today. And also thank you for all you're doing to advocate for dental health, and particularly sugar-related tooth decay. And on a positive note, I actually met with Greg Hunt yesterday, and we had an excellent meeting, and he's pledged to really tackle the issues of the preventable and reversible nature of type 2 diabetes in our society. So, watch this space. I'm also giving a National Press Club address in December. I'll be talking about this, and I'll also be filming with Michael Mosley, the doctor from the UK, in his 3-part documentary series for SBS. So again, we'll be addressing some of these really critical issues. But we need Australia, we need the medical profession, we need the dental profession to embrace all of these really important issues that are impacting on our very poor metabolic health. And just on a final note, in America, there are more thin, metabolically unhealthy people than there are overweight or obese, metabolically unhealthy. So it's not obesity per se, which is the problem here. And it's not even the amount of calories, it's the type of calories. And in particular, it's the sugar and the refined carbohydrates which are driving this. So people can be left with one message: just minimize the amount of sugar and refined carbs that you're ingesting. And I'm sure that we would see a huge difference in the amount of chronic disease. Type 2 diabetes also has links to hypertension. Hypertension is the leading risk factor in heart attacks. It also has links to stroke and also to cancer. So if we can curb our sugar intake, I think we'll see a significant drop in chronic disease in the future. And so hopefully the listeners will embrace what we've spoken about this morning.
Dr. James Muecke, after listening to you, I'm sure that they will, and it's such a powerful message. And thank you again for all your work, and we'll hope to be chatting soon.
Thanks, Steve.